Good morning, everyone. Please, if anyone can hear me, if you can just let me know so that we can make a start today.
Yeah, we can hear you. Good morning.
Perfect. Good morning. Yes, so I think we should make a start. It's way past 7 o'clock, so um, we should get into what we have today so that everyone can go about what they need to do. I want to sincerely thank you for joining this class this morning. My name is Olalekon Gugwemi, and I'll be taking you Gastro 1. And over the weekend, we've been having our revision for the mock series. It's very interesting to see different people thinking in different ways, and that shows our diversity. But what we need to know that the AKT, there's a particular way of thinking, there's a particular way of problem solving, and those were the type of things we're trying to establish yesterday. So it has been made clear that it's not all about the scores you get. It's about understanding the way to think in the AKT. It's about the speed, which quite a lot of people had recognized. Well, the AKT is an exam that quite a lot of people have passed, and every single exam, a lot of people are passing, which means you can not just pass, you can do excellently well in it. It's not a very big stumbling block. It's just that you need to do the work. And that's part of what I've emphasized yesterday, that everyone in the EasyLearn community has to be ready to do the work, and we'll guide you to doing the work. So this morning we're going to be looking at gastro. In the same light, I want to encourage everybody that although gastro has a lot of things, and the reason why we've broken it down into gastro 1 is meant to be gastro 1 and 2. But just because on Sundays we are restricted to about 2.5 hours maximum, what we have done is to make gastro 1, 2, and 3, just because there are a lot of things to cover and we don't want to rush it. If it is possible, we can make it gastro 1 and 2 and do the rest during our drills. By the way, the drills are the most helpful things in the course, the drills and the mocks. So please, I want to beg everyone to try and attend the drills. I know some of them are a bit lengthy towards the examination, but it's just to make sure everyone passes as a team rather than a few people pass the exam and leave the other ones behind. So it's just in that light that we try to repeat some things and make sure everyone is on the same page. So today I won't take so much of your time. I just want to beg you that at this point, it's about 6 weeks to the exam. You should be doing at least 2 hours of daily reading. On the weekends, you should be doing at least four to 6 hours of what we call targeted reading. Don't read jargons, my friend. It's something I say every day. Don't read things that you don't need to read. Be streamlined. Read only the things that are important. For example, we're going to talk about Crohn's and ulcerative colitis. It's a big topic and there are a lot of jargons. Jargons is when you start to read the founder of the true love and wit criteria. You don't need it. All you need is the true love and wit criteria. Less than 4, 4 to 6, greater than 6. Jargons is when you start to read all the things that make up the true love and wit criteria for people that need to be in hospital. Systemic systemic problems or stools greater than 6, hospital. You don't need to start reading half a page to know who meets hospital criteria. So that will be jargons to me. Jargons is when you spend so much time reading primary sclerosing cholangitis. You read 3 pages. Meanwhile, primary sclerosing cholangitis is just an associated feature with IBD. That is jargons, my friends. So, particularly 6 weeks to your exam, you have to restrain yourself. You have to make yourself understand that reading jargons is not helpful to me now. And so that's why I want to beg all of you to be streamlined with your reading. So if you have 4 hours, I know you have things to do. There are quite a lot of things happening in the weekend. There are parties, there are programs in churches, there are people wanting to shop. There are other important life events. And so if you have only 4 hours to read on a weekend, on a Saturday, for example, I'll use my 4 hours for the most important things. I'll use my 4 hours for high yield stuff. I use my 4 hours for things that I know will come out. How do you know things that will come out? It's all written on the RCGP website. It's those things you see every day. So I want to beg you. I want to challenge you. Don't just read, don't just study, be in a study group and study the things that come out, which are the high yield stuff. Those are the things you see every day. So let's go into gastro today. So we've named it gastro 1, just so that you know that we've broken it down into series, like I've said. And we'll be starting up with Wilson's disease, my friends. So what is Wilson's disease? Well, Wilson's disease is basically excessive copper deposit in the tissue. It's just excess copper in the body, that's all. So don't try to make it too difficult, too cumbersome. It's an autosomal recessive condition, just like hemochromatosis. What have I just done? I've done compare and contrast. This is how you study. Wilson's disease, autosomal recessive. Hemochromatosis, also autosomal recessive. How do you fail these things in the exam? So you already know the ways to remember autosomal dominant, and you know the ways to remember autosomal recessive. It's something that we'll still do in the drills again. The ones that are structural, the ones that are ataxic and anemias. You need to know all of them. So, but that's not the focus of today, and we've got limited time. So I'll try my best not to do a little here, a little there. But you know that that's the most important thing, that when you study Wilson's, you need to touch hemochromatosis. When you touch hemochromatosis, there's no way you will not read about iron deficiency anemia. Of course, if you are reading about iron deficiency anemia, hereditary ferrocytosis, and glucose 6-phosphate dehydrogenase disease are topics to read. This is how people should read. A little here, a little there. How do you go into the exam knowing everything about Wilson's, but knowing nothing about hemochromatosis and knowing nothing about iron deficiency anemia? It's unheard of. Don't know about hereditary spherocytosis, and you don't know about glucose 6 dehydrogenase disease. Have to know about fava beans. You have to know about sulfonamide. You have to know about the sulfur triggers of G6PD deficiency. So, my friends, this is how to study. One topic it is a chain reaction. One topic reminds you that, oh, I've not studied that one. As you are studying that one, you move there, you go and study the most important things. As you are finishing that one, before you finish, it reminds you that hereditary spherocytosis can come out in the exam. You go and look at how it presents. You look at the differences between hereditary spherocytosis and glucose 6-phosphate dehydrogenase disease. You don't go wrong. You can't go wrong. The candidate that goes to start to study something like dysphagia and reads esophageal cancer for 15 minutes, when he can read dysphagia and cover 18 causes of dysphagia, he is a candidate that is not reading with the right systems. Okay, so Wilson's disease, autosomal recessive, hemochromatosis, autosomal recessive. Wilson's disease is excess copper deposit in the tissue. Hemochromatosis is disorder of iron absorption. So one is excess, the other one is normal iron, but the body is refusing to absorb it. Can you see the difference? Use these differences to enjoy your reading. Well, while it's defect in ATP7B, that's what's causing Wilson's disease. So the ATP, which is your energy, at 7B, so there's an ATP7B gene, which is located in chromosome 13, is defective. Let me say that again. ATP7B gene located in chromosome 13 is defective, and that's the cause of Wilson's disease. But let's look at hereditary spherocytosis. There's inheritance of a mutated gene. It's called HFE gene. And both of the copies of this are on chromosome 6. How do you fail it? Wilson chromosome 13, hemochromatosis chromosome 6. Look at how I'm doing it. ATP7B gene is the problem in Wilson disease, as the HFE gene, hemochromatosis ferrous gene, is the problem in hemochromatosis. How do you feel these things? So, my friends, this is how to do it. You differentiate, you remember. You read it, you forget after some time. So that's the definition of hemochromatosis. I've made it very simple. Even in the definition, I've told you that it's autosomal recessive. I've told you the problem, ATP7B gene, while hemochromatosis is the HFE gene on chromosome 6. So Wilson is chromosome 13, hemochromatosis is chromosome 6. Well, we need to talk about how it presents. What's the difference between Wilson's and hemochromatosis? Why Wilson's first presentation in adults will usually be neurological problem. Whenever you think about Wilson's, think about neurology and liver. Wilson's, neurology, liver. Hemochromatosis is much more broad. It's also liver. So there are similarities is liver. Both of them affect the liver badly. But while Wilson's does a lot of brain damage and neurological system damage, hemochromatosis will do a lot of systemic damage. How do you feel it? Wilson's neurological, hemochromatosis systemic. So in children, usually it's their liver that is damaged because their liver is still not very well developed compared to the adults. The liver can still be hit by a lot of things, and so their liver suffers quickly. But in adults, it's the brain. In children, the liver. The adult, the brain. And when I say adult, I'm talking of 18 to 25. When I'm saying children, I'm talking of less than 17. How do you feel it now that I've made it like this? So what's the typical onset of Wilson's? If you are seeing 10 to 25, you are correct. If you are diagnosing Wilson's in a 51-year-old patient, you are wrong. You are wrong. So Wilson's picture, the question will come out as a 24-year-old male who is now having yellowing of the eye, jaundice, has now been admitted to the mental health ward. What do you think? Neurological problems, neuropsychiatric issues. So let's look at some of the symptoms, the areas that Wilson would like to deposit copper in. So the problem here is the excessive deposition of copper into the major body organs, causing the problems we are going to face. So when Wilson's deposits too much copper in the brain, neurological symptoms. If it deposits too much in the liver, that's when the children start to have liver problem and the adults start to have jaundice. Well, it can deposit in the eyes. That's where it causes corneal problems, corneal opacity, which we are going to talk about now. So how do I remember the symptoms of Wilson? Please look no further. I've helped you with an acronym that will make sure that you don't forget Wilson's. If you remember Wilson's, remember lenses. Use the lenses of the AKT to look at Wilson's. How do you feel it in the exam? What do I mean by lens? Well, the lens of Wilson's disease is liver problems. Wilson's can cause all sorts of liver problems. The commonest will be hepatitis and liver cirrhosis. So Wilson's is a cause of hepatitis. Wilson's is a cause of liver cirrhosis. Cirrhosis, will end up in hepatocellular cancer. How do you feel it in the exam? Well, if it's affecting the eyes, is that brownish, greenish stuff you see in the eyes. That ring is called Kesha-Fletcher's ring. Don't feel it. They are describing a greenish brown ring in the eyes. They are talking about Kesha-Fletcher ring. This is the deposit we talked about that affects the eyes. That's the E in lenses. The N are double, so you can make your lens NN, but I've just left it as one so I don't complicate things. Make things simple for yourself. When you make things too complex for yourself, you end up failing the AKT because you are just muddled up. Everything is just everywhere. Make things easy for yourself. We are further making things easy because your flashcards, we are putting all the clinchers, all the acronyms, we are putting everything in cardiology on one flashcard page. We are putting everything in neurology on one flashcard page. We are putting everything in every of the courses on one flashcard page. Everything is together. You want to do a quick revision for the AKT, 1 hour to the AKT. You look at 10 minutes of cardiology, you complete it. You look at 20, you do another 15 minutes neurology, you complete it. You look at gynae, you complete it. You want to look at hematology, you complete it. It's taking very small time. This is how to be organized. And that's what we do at EasyLearn. We help you with organization. We know sometimes it's very difficult to be organized. So what's the other end? Their nails, if you look at it, is bluish. It looks like a cyanose nails. So it's bluish. Wilson's disease is a cause for blue nails. And of course, the last ones are the systemic problems. My friends, think renal tubular acidosis. Where else do you see renal tubular acidosis? AKI. Please don't forget pre-renal, renal, and post-renal causes. Post-renal causes will be obstruction. Pre-renal causes will be diarrhea. Pre-renal causes will be sweating. Pre-renal causes will be vomiting. Pre-renal causes will be anything that will cause loss of water or dehydration. The renal causes, think acute tubular necrosis, ATN. Don't fail it in the exam. Renal artery stenosis is a renal cause. Well, let me leave that for nephrology because we've got limited time. When you see the S in lenses, then you know it's systemic. Think hemolysis. A patient with Wilson, what happens is that after some time, they start to have hemolysis. Don't fail it in the exam. So I just thought I would present something that will make your life easy. Wilson, you need to use a lens to see that it's autosomal recessive. You need to use a lens to know that it's the commonest problem is neurological in adults and in children, liver disease. You need to use a lens to see the defects, ATP7B on chromosome 13. You need to use a lens to know the clinical features. You need to use a lens to know the investigations. My friends, in the AKT, low serum ceruloplasmin is Wilson's. Low serum ceruloplasmin is Wilson. High urinary copper is Wilson's. So when you see that the copper in the urine, you take 24-hour urine, there's a lot of copper. You are dealing with Wilson, my friend. You check the serum copper is low. You check serum ceruloplasmin is low. That is Wilson, my friends. So while urine is high, serum is low. Don't fail it in the AKT. So you need a lens to look at all these things. Don't forget the lens. Don't forget the lens, the liver, the eyes, the nails, and the systems. That's what it affects. If you remember these things, you're good to go. Again, this all the other systemic problem, Wilson's causes neuropsychiatric issues. It affects the brain. Wilson's is a cause of Parkinson's, my friends. Wilson's can cause all the other problems. So don't fail it in the exam. Wilson's causes dementia. It's a cause of that as well. So don't fail it in the exam. You see it, you can't fail that in the exam. So just to keep things simple, I'll just go straight into the diagnosis and the management because that's what you need, my friends. So in the diagnosis, once you've got urinary copper, you've got serum copper, I think that's enough for you in primary care. But if you want to go ahead, they're asking you gold standard, what you do in secondary care, where you can do this test is a gene analysis because I've told you that the ATB 7B gene is a problem. What you need to do is genetic analysis of this gene. Look for it. Is it defective? Check on chromosome 13. Is there a problem? If there's a problem with ATP7B gene, then you've made your diagnosis. Well, that test is not very common. It will be the confirmatory test or the gold standard. You remember your management is still your penicillamine, and people don't find problems with this. Please, trientine hydrochloride is an answer in the exam. At some point, it was forgotten, but it's still now being used and has been relegated to second line. In the exam, allergies to penicillamine, the answer is trientine hydrochloride. In your exam, on the options, there is no penicillamine. Your answer is trientine hydrochloride. Please don't fail any question on Wilson's disease. Wilson's disease is the easiest gastro topic that you can have in the exams. So I just thought we should look at that and then from there get into hemochromatosis because they are
Sorry,
friends. Yes.
Dr. Lekan, first line is still penicillamine, isn't it?
So that yes, there was a time that they put trientine hydrochloride. The guideline was changing; it was coming back. Penicillamine will be the answer in the exam.
Okay.
If you see trientine hydrochloride, it will still be correct. If you don't see penicillamine, so
Okay.
there was a time triantine hydrochloride was kicked out of the guidelines. It's back on the guideline as can be used as well. So it will be a second line for now.
Okay.
I think in the exams, the ones that you usually see in all the exams will be penicillamine. So if you check, even in the Canadian exam, it's still penicillamine. They hardly put triantine hydrochloride, but I just put it on the slide so that in case you see that is a correct answer. So if you are looking for penicillamine, you are not seeing that triantine hydrochloride will be the answer.
Okay.
That will be the answer. Okay.
Please, can I ask a question?
Yes.
Yeah, sorry, I'm just trying to understand. If there is low serum copper and high urine
Yes.
copper, what is making the copper to be then depositing in the liver and the brain if there is low serum copper?
So now they are not in the blood any longer. They've been deposited in the tissue. So in the tissue, there's a lot of copper. The copper is just lying there. It's low serum ceruloplasmin and high urinary copper. So that copper is being excreted because it's useless. The body is not using it. Does that make sense? Ceruloplasmin is the transport medium for copper. That's what takes the copper around. Does that make sense to you? So, but this copper is free copper. The body is supposed to be using it, but the body is defect. There's a defect. It's producing too much. So he has to look for places to hide. That's why they are going to hide in the brain. That's why they are hiding in the liver. So this serum, this transport medium, there's just so much to go around. So the body just starts to excrete it. That's why you have so much copper coming out in the urine and so little because it's not being used. So that transport medium cannot bind to copper to use it because there's just so much around and they are going to hide in the cells, causing problems. Okay. I don't know if that's clear.
Yes, it is. Thank you.
So hemochromatosis, we've just talked about the autosomal recessive, and I've told you that the disorder of iron absorption is the problem here. So it's not excess here. Is not the normal amount we have is not being absorbed. And so because it's not being absorbed, that's how it accumulates. So it's different from Wilson's where there's excess. So you can see the difference. Normal production, the excess there is defective gene. Here there's normal production, but the problem with HFE gene is that it's not being utilized. So if it's not being utilized, it will accumulate and behave like Wilson's disease. It will start to go and cause problems. So I've told you about the HFE gene as being the problem. And you can see again the difference. Please don't forget chromosome 6 and 13 are the differences in the chromosomes. So when this starts to accumulate, usually it's not a problem at the beginning. But with time, if it starts to become, if it builds up in the body, then there becomes a problem. And this problem affects every part of the body. That's why we call hemochromatosis multisystemic. Please mind you, hemochromatosis can run in the family because it's genetic. So grandfather can have it, granddaughter can have it. So don't fail it in the exam. It's genetic. HFE gene is the problem there. So let's look at the main thing. How does it come? It's how it comes. If you don't recognize that they are talking about hemochromatosis in the exam, you fail the question. And that's why sometimes I'm very particularly about how it comes because when we're looking at some of the mock questions, some of the things I discovered, candidates did not know, they didn't have a picture of how a question comes in the exam. And if you don't have a picture of how a question comes in the exam, then you can't even get the answer. Sometimes you see what they have done is they've put iron deficiency anemia, they put hemochromatosis, and they put some other iron related problems as the options. And they are talking about iron. The candidate is defeated. You can't afford to be defeated in the AKT. And this is why you need to know the picture. And that's why anytime I'm talking, I emphasize on the symptoms, how it comes in the AKT. I've told you in Wilson's disease, if you are seeing a 55-year-old, it's likely not Wilson's in your AKT. But I've told you the age range. It's still a young person. Look at 10 to 25. Highest, look at 10 to 30. That will be the range of diagnosis of someone with Wilson's disease. But in hemochromatosis, while you are looking at lens in Wilson's, in hemochromatosis, you are looking at bad cells. Bad cells will help you to remember how the picture will come. Is someone I call someone that has bronze skin diabetes. How do you fail it in the exam? A patient with bronze skin diabetes is hemochromatosis. What does that mean? Their skin is unnecessarily dark and shiny. There is a lot of iron deposits. So when you see a bronze skin pigmentation on the skin of a patient, the patient is having widespread spread arthralgia. The patient is complaining of arthritis at a young age. The patient suddenly has diabetes. What do you think? We are dealing with hemochromatosis. So the bad there is the bronze skin, which is the color of the pigment you see in hemochromatosis. Arthritis is a common early feature. So once you see that they start to have symptoms, the first thing you may start to see is joint pain, and this joint pain may be diagnosed as arthritis. So how does it help you? A young patient, for example, in his 30s, is already having arthritis, and the patient has diabetes. He doesn't have type 1. He has at some point they diagnosed diabetes at the age of 31. It's already putting a picture in your head. You are reading a question, past medical history of arthritis, and now he has developed new onset diabetes. What do you now look out for? Does he have a skin pigmentation? Bronze skin pigmentation is a clincher in the exam. Sometimes they don't put this. What do they put? They say the patient has erectile dysfunction. Don't fail it in the AKT. A man with erectile dysfunction, new onset diabetes, the erectile dysfunction is not due to diabetes. So some candidates yesterday during the mock, they say, but this can cause this. Well, diabetes can cause erectile dysfunction. But in a question where they are trying to ask you about hemochromatosis, they put diabetes in the question. They say the man has new onset erectile dysfunction, and they are asking what's the cause of his erectile dysfunction. Meanwhile, in that question, they put that the patient has bronze skin, he has a bronze skin pigmentation. They said, what is the likely cause of his erectile dysfunction? A, diabetes, B, hemochromatosis. Now, let me teach you how to think. If you've picked diabetes as the cause, diabetes can be the cause. But if you pick diabetes as the cause, you fail that question. And this is why I beg you to see how to think in the AKT. The AKT is not like your usual exam. You need to understand the mind of the person that has set the question. You need to understand the mind of the examiner. How do you understand the mind of the person that has set the question? You follow the picture. You follow what we call pattern recognition. You use clinchers and cliches. So what the clichés and cliches here is put bad together and pick that the cause of erectile dysfunction in these patients is hemochromatosis, not diabetes. So don't use your usual thinking that yes, this patient that has come has had diabetes for a while and the cause of his erectile dysfunction is diabetes. You fail it in the AKT. In real life, yes, you may be correct, but the AKT, you must think like the AKT. And this is why I'm begging you that whenever we're looking at questions, look at the picture. That picture is necessary. There's something in the question that makes option A, diabetes, wrong, and option B, hemochromatosis, correct. This is the kind of picture, this is the way I want you to think. Some candidates have failed the AKT, not because they don't know what they are doing, because they are thinking generally, because they are thinking in the odd way for the AKT. The right way to think in the AKT is to bring the picture together, the picture of pattern recognition, that picture that clinchers and cliches will give you. I know why I've hammered on this, because yesterday there were a few questions that candidates were not easily comfortable with because they didn't understand that certain things mean certain things. And in the AKT, they've made it very difficult. They put answers that are closely related. This is how not to fail it, to understand how that picture will come in the AKT, to pick the answer in 10 seconds and move on. Okay, stigmata of CLD, please, you see the patient having all your stigmata of CLD. Please go and know how CLD stigmata will come in the exam, or the caput medusae and all that. Patient, again, you can see that liver disease is a problem here. Hepatomegaly and cirrhosis is a top problem. Now, if you are thinking in your question, and I always tell you how the question will come. I always tell you, in your question, you will not see that the patient has hepatomegaly. You won't see that. You may see it on examination, you may not see it. But if you are particularly waiting for cirrhosis, it won't be there. They will give you a biochemical picture of the LFT. and then you see that this LFT is deranged. What does that tell you? Deranged LFT with bronze skin pigmentation is equal to hemochromatosis. You see some slides, rather than put a topic like hemochromatosis, I start to tell you a picture. I just start to put pictures together, and I'm going to do it today. When we get to dysphagia, you see that rather than me talking about esophageal cancer, one topic is a waste of time. I don't have that time. I just need you to see this is a course that helps you. You have 6 weeks. How do you read 12 or 15 courses of dysphagia in 5 minutes? You can't. But how do you create the picture of dysphagia in 5 minutes? You can even use less than 3 minutes. Today, when I talk about dysphagia, you see how I'll cover 10 courses of dysphagia or more in 5 minutes. And I'm covering only the important things. My friends, this is the AKT. If you go around trying to become a professor, reading topics like esophageal cancer and trying to cover everything using 20 minutes, trying to be good, you are planning to fail the AKT. I can assure you, you won't have time to study other things. And this is why you have to be targeted. Some people in the AKT, what they have done is they are very good in hemochromatosis. They did not have time to read Wilson's. The question in the AKT in gastro was Wilson's. How do you feel? How do you feel that you didn't read it and you failed it and it was an easy question? This is why my strategy is touch everything. But as you are touching everything, touch only the important things so that you have time to touch everything. And this is what I want you guys to do as you go into the AKT. So that is bad cells. You now know that the difference between lenses and bad cells. I don't think anybody will fail it. But let's move forward. Hemochromatosis, please, there are some causes of hypogonadotrophic hypogonadism. In infertility, we're looking at Sheehan's. We're looking at Sheehan's syndrome. Now, today we are looking at hemochromatosis. Don't fail the question in the exam. The cause of the hypogonadotrophic hypogonadism is secondary to the cirrhosis that happens. It's secondary to the pituitary dysfunction that happens. It can be any of these things causing it. So you need to know the causes of hypogonadotrophic hypogonadism. During our revision, these are some of the things we'll be doing. You won't be seeing anything like hemochromatosis. You won't be seeing anything like Wilson's disease. All you'll be seeing is pictures. In the AKT, you read question 1, you should see 6 pictures. By the time you are on the second line of question 1, you should have reduced to 2 pictures. By the time you are reading the question, which of the following will be the most appropriate? You have 1 picture in your head. This is how to think. And if you are going to the AKT, you will see quite a lot of questions. Which of the following is the most appropriate? What does that mean? Every other thing is appropriate. We've seen these questions yesterday in the mock. Every other thing is correct. Every other thing is appropriate. Which of them will you work on first? Most appropriate. Please, please, and please, there's always a rationale behind most appropriate. They are tricky questions. And the rationale is in the head of the person that has said the question. That means you need to go into their mind and their head. How do you exhaust the guideline? The guideline is sometimes, I've told anybody that is going to read the nice guideline, you're wasting your time. What you need to do is to understand how the question comes. If you understand how the question comes, there's always something in the guideline that may invalidate something else. But if you understand how the question comes and what that person who is the examiner is trying to put, the picture is trying to show to you, you will get that question. So always understand the picture that has been created by the question. If you understand it, you get the answer. Anybody that doesn't understand, that's why sometimes when we're doing the mock, I ask the candidate, can you tell me the picture? What picture is in your head? I didn't, because it's easy. If it's tell me the answer, that's fine. We would have just sent all the answers to your emails. Go and read it. Goodbye. Thank you very much. No, is to help you understand how to answer questions. Get a picture in your head. Those candidates that have picture in their head score 90. The candidates that don't have picture in their head, they struggle to pass. And I know these things. Get a picture in your head. So in hemochromatosis, if you have the picture, bad cells in your head, you will get all the questions. In the investigation, transferrin saturase is first line. Ferritin is not always positive. It's usually positive late disease. Early disease, ferritin will mislead you. So transferrin saturase is your gold standard. Transferrin saturation will be your gold standard in the AKT. If it's a family member and you are trying to do what we call gene testing, so this patient that has come to you and said, my brother, so if you see a question, my brother has been tested for hemochromatosis, what do? HFE gene testing. But if this same candidate comes in and starts to say, oh, I'm having symptoms of bad cells, is transferrin saturate. Don't fail it in the AKT. HFE gene testing becomes the answer when it's just what you are doing is a relative has got the condition. But transferrin saturate becomes the answer when a patient actually has symptoms and you need to confirm. In the absence of transferrin saturase, second line is ferritin. It is not the best test in early disease. I don't think anybody will fail these things with the way we've explained it here. And I just thought I should bring a picture for you here. Low TIBC, hemochromatosis. High TIBC, iron deficiency anemia. Please don't fail it in the AKT. So you need to be able to differentiate, which I'm not going to do today because we have capped our time today. Everyone is going to go home early today. But what you need to be able to differentiate is these three things. In iron deficiency anemia, what happens to transferrin saturase? In iron deficiency anemia, what happens to ferritin? In iron deficiency anemia, what happens to low TIBC? Why am I emphasizing on it? Why must you know it? Because that may be the reason you get the answer as iron deficiency anemia. They paint a long picture. They make it a vague question. They don't make it very clear that they are describing iron deficiency anemia, but they put a blood picture. That blood picture may be the one to help you to know that we are dealing with iron deficiency anemia. So don't fail it in the AKT. Well, so in hemochromatosis, venesection can be done. You can give medication. Desferrixamine is still the answer in the AKT. It does chelation and venesection. All of you know that, so I'm not going to spend time on things that you guys already know. I'm just going to spend time on building a picture in your head. That's usually the problem. When the candidate knows what the question is asking, they get the answer. Many of them know the answer, but the reason why they fail is they fail to understand the question. They fail to understand the reasoning behind the question. So you can always go through the management of these things quickly and understand them. Please, the AKT time is not for reading how venesection is done. Point 1, admit to hospital. Point 2, give calcium. Don't do that. Just know what the management, what's first line, what's second line, what do we do if a first line is not there, what do we do if second line is not. That's all you need to know. Don't go and start reading side effect of this. It doesn't come out. If you want to read side effect of a medication, read the side effect of ACE inhibitors, read the side effect of statins, read the side effect of calcium channel blockers, read the side effect of bisoprolol, read the side effect of phenytoin, read the side effect of cyclosporine, read the side effect of cisplatin. These are the things to read the side effect of, not desferrixamine. It won't come out in your AKT, my friends. Okay, I thought we just needed to do a bit on that, and we've done that. IBS. Well, this topic was supposed to be taken alongside IBD, but IBD is broad. And on the same day we are doing IBD, we are doing another broad topic. So what I've done is I've just basically carved out IBS from there. And I said, let's talk about IBS differently on a day when we will not be stressed. IBS is easy. It's your ABC. Abdominal pain, bloating, and change in bowel habits. I know you know it. And any other 2 symptoms. 2 symptoms can be mucus. 2 symptoms can be straining, urgency, incomplete voiding. 2 symptoms can be relieved on defecation. It can be worsened by eating. 2 symptoms cannot be weight loss. Weight loss is a red flag. It's a 2-week wait. 2 symptoms cannot be family history of bowel and ovarian cancer. My friend, that's a 2-week wait. I mean, if you see a patient having unexplained rectal bleeding and you choose IBS, you fail the question. What are you doing? IBS doesn't have rectal bleeding. It's a red flag. That can be IBD, that can be colorectal cancer. A patient with change in bowel habit plus rectal bleeding, 2-week wait, my friends. What are you doing? While you are planning to do your fit test, in fact, if the bleeding is too much, I've done it several times. Bleeding is too much, there's no need for your fit test. Just write, this patient is having active bleeding. Every day, the patient has been passing blood in stools. Don't wait for any fit test, my friend. Send for a 2-week wait. Tell the specialist you'll be glad if this patient can be seen as soon as possible, even in your 2-week wait, because that patient is likely to have colorectal cancer and you are doing your fast track referral to secondary care. So let's talk about IBS. So that's your abdominal pain and it's worse with eating and relieved by defecation. Don't fail the question. Well, you are seeing a patient that is bloated and that patient is 52 and you are diagnosing IBS, is a red flag, my friend. The patient is 63. What are you diagnosing IBS for? That's ovarian cancer, my friend. Ovarian cancer, bloating, vague symptoms in a woman above the age of 15, in a woman in the menopausal age range, is ovarian cancer until proven otherwise. It's a 2-week wait. Diarrhea, bloating in a female above the age of 50 is a 2-week wait. I don't know how else to tell you. I don't know how else to say it. I know quite a lot of you know it, but they twist the question, you fail it in the exam. This is how they can twist it. They can twist it in 10 different ways with the vague symptoms. In fact, you will see a mock question where they'll put no bloating, no diarrhea. It's just the patient has on and off abdominal pain and it started when she was 53. What are you doing? It's a 2-week wait. That's one of the vague symptoms. So what do? CA125. If your CA125 is greater than 35, that's good. You refer. If it's less than 35, that's good. You still refer. CA125 is not very sensitive. Is a specific test. Is not you need to know the difference between specificity and sensitivity in the AKT. It comes out whenever you are doing your statistics. Sensitivity, specificity comes out in the exam. And don't fail questions or that are so simple when they actually, what's the definition of specificity? When you start to fail that question, you are already planning to struggle because they are the easy ones in the exam. Well, you see a patient, CA125 has come back normal. Please, if she has symptoms in keeping with ovarian CA, please still refer. Still refer. If you are worried, refer. If the picture is looking, that's why I always create a clinical picture. No matter, never rely fully on investigation. Sometimes they can fail the doctor. So if you see a picture of ovarian cancer, CA125 is not a reason not to refer your patient. I think I've overflogged that. So bloating, distension, tension in the tummy, all the other things, hard tummy, all these things can be IBS in a younger patient. Of course, you're changing bowel habits. Please think about a patient that is straining. It's not always hemorrhoids. A patient that is having urgency it's not always what you think it is. It can be anything. So have a broad open mind. Incomplete voiding, urgency, straining with changing bowel habits, IBS can be the answer in the AKT. Okay, so I just thought I should let you know about the red flags, and I've mentioned them. I'll say them again. It's good to say this thing twice. Rectal bleeding is not in IBS. Unexplained weight loss is not in IBS. Family history is not a feature of IBS, especially family history of bowel and ovarian cancer. Please, please, please be planning to refer this patient with or without fit test, with or without CA125. Of course, I've told you a woman above the age of 50, think ovarian cancer. Patient above the age of 60 is hardly IBS. You need to be sure that there are no red flags before you make that diagnosis of IBS. Because at the age of 60, IBS is kind of rare. He should have brought his head up before that age. Okay, I just thought you should know some of these things. Let's talk more about the management of IBS because they come out in the exam. Fecal calprotectin is for your IBD. A patient with fecal calprotectin less than 100 is likely IBS. Think about it. No blood, symptoms in keeping with IBS. You did fecal calprotectin, your fecal calprotectin is less than 100, think IBS. Greater than 100 is less likely IBS. It can be IBD. What am I talking about IBD for? Ulcerative colitis, Crohn's disease, If you see a picture of fecal calprotectin again at about 250 or more, just refer to secondary care. That's IBD you are dealing with. Above 100, suspect, refer on a base of suspicion. But above 250 is almost likely to be IBD. Less than 100, it will never be IBD. Forget it. So think other things. And one of the other things to think about is IBS. So these are not investigations for IBS. They are investigations to exclude other things that may present like IBS. Of course, you know your TTG in celiac disease. You need to know how all the tests that we can use. IgA TTG. If there's no IgA TTG, what other tests can I use? There are 4 of them. My friends, you need to have them at your fingertips. Well, your CRP will help you. A very raised CRP, please think IBD. Very raised CRP, think diverticulitis. Diverticulitis is the picture when you see left lower quadrant pain in an older patient with blood in stools. Ulcerative colitis is where you see left lower quadrant pain, blood in stools in a young patient. Someone didn't get that very well, and the person is planning to fail it in the AKT. Can I make sure you don't fail it in the AKT? A young girl who is 19 years old, left lower quadrant pain, blood in stools is ulcerative colitis. A 61-year-old female, left lower quadrant pain, blood in stools is diverticulitis. How do you fail it? Now that I've put a mental picture in your head. So candidates read it, they see A, ulcerative colitis, they see B, diverticulitis, they rush to pick B, diverticulitis when it's a 21-year-old girl. What are you doing? Well, they rush to pick ulcerative colitis when it's a 54-year-old woman. What are you doing? That's diverticulitis. That's why in the AKT, I tell you all the options are very close. Quite a lot of people were shocked. They were already very sure that the answer that they picked is correct. There's only one thing that differentiates. I want to beg you, that thing that differentiates it is what we are teaching in Easy Learn. That is the clincher. Everything can be. That's why sometimes I tell you this is not non-specific, this is non-specific. I drag one thing particularly in the question. I say this thing is over 90% the strength of this question. I tell you that's how you know this question. In these 2 questions I've talked about, the age is the super clincher. The age is the super clincher. Every other thing looks the same. They've made it a bit vague. They've tried to make sure that you do not know it's ulcerative colitis. But when you see the age, is the super clincher. 70-year-old female, 62-year-old female, please, please, please think less of ulcerative colitis. Well, if you are seeing 18-year-old female, it cannot be diverticulitis. It cannot be. So anybody that is thinking that, remove it from your head. This is how we are teaching you to think. If you think like this, you get 90 in the AKT. If you think otherwise, and this is the problem with reading. So people read too much. They read everything. They read the symptoms. They read so much that when they see the question, they cannot organize the picture in their head. Stop reading. Start organizing. Organize pictures in your head. Our teaching is not at making you know topics, is get at making you understand. If it's get at making you have knowledge, would have just been doing teaching sessions. We increase our teaching sessions, we change our drills to teaching sessions, we take our mock to teaching sessions. That's not the aim of the AKT. Stop reading, start understanding. Stop reading, start knowing how to convert your knowledge into answering the questions. Part of the problem we had yesterday with a lot of people is interpretation problem. I know some people have found out that speed is a problem. Some people found out other things is a problem. Majority of you did not say the main thing. The questions you failed is interpretation problem. The ones that got the question is because they could interpret. There was a question we got to at some point. It was carcinoid tumor, carcinoid syndrome. Quite a lot of you had the picture of paraneoplastic syndrome and other syndromes, but it was carcinoid syndrome. Someone had the understanding, and the person did it very well. The person mentioned 3 things. He said, I'm seeing cancer here. The person said, I'm seeing diarrhea here. He called the 3rd thing, but cancer and diarrhea is already painting a picture. That's not paraneoplastic syndrome, my friends. Then he sees a third thing and says, no, this thing has to be carcinoid syndrome. And the person goes ahead to pick the right answer. It's because you have you have created a mental image. All the people that failed it, they failed to create a mental image either because of two things. Either because they've not come across the topic, that means they've been reading other topics. They spent 1, 2, 3 hours reading paraneoplastic syndrome, forgetting that it may not come out in the AKT, and they've forgotten that carcinoid tumors or carcinoid syndromes can come out in the AKT. Or they've read carcinoid syndrome, but they've not created a mental picture. The moment you read something and you don't create a mental picture, you are likely to fail it. So always create a mental picture. And that's why anytime we are going through these things, we create a mental picture for you. I tell you how it will come in the AKT, not because I've seen the question, but it cannot come in another way. Okay, look at the management for IBS. Let's look at the first line. Make your life simple. CBD is what you need to know. Constipation, pain in the abdomen, diarrhea. That's what you need to manage. Every other thing, apart from the lifestyle management, is a waste of your time. Well, patient is constipated, nearly all the laxatives will go. Ispagula husk is an answer in the AKT, my friend. Use it. Senna is correct. Who says Ducosate is not the answer? It is the answer, my friends. So anything, all your laxatives can go, but the only one that will not go is lactulose. Don't fail the question. Lactulose, no, no. Even linaclotide will go, not as first line, but as a backup. It will go, but the only thing that will not go is lactulose. So what image am I trying to paint? Whenever we come to IBS, remember, whenever we are talking about constipation, remember the 3 L's. What are they? Laxatives, all of them. Lactulose is a no-no. Laxatives is a yes. And when all the laxatives fail, linaclotide is the answer. Can I go again? Your 3 L's. All laxatives will likely be correct, but lactulose is a no-no. If they all fail, linaclotide is your answer. Don't fail it in the AKT. Well, you've seen a patient having general abdominal pain and there's a bit of bloating. Hyoscine will help. Mebeverine will be the answer, and I'm sure you guys have prescribed these things, so you know them. Well, if the patient is having diarrhea, you know that loperamide will be what we'll be using, anti-diarrhea medication. It will be correct in the AKT. So these are the first line, and I've told you that if the laxatives are not helping, your linaclotide will help. But let's look at other pictures. What else can happen in management if these things are not working? Because IBS can be a bit stubborn. The patients will come back, they'll be demanding for CT abdomen. Some will say, I want colonoscopy. You say, but there's no red flag. There's no indication for me to refer you. I think, madam, I think this is IBS. The patient has gone to read about it. They say, no, I don't think it's IBS. But you are seeing all the symptoms they are talking about on the IBS community website. You are seeing it on the IBS Society UK. And they are saying this, I don't think this is IBS, just because it's not getting better. What do you do? Well, for your patients that are not getting better and you still think it's IBS, there's no red flag, you've ruled out rectal bleeding, you've ruled out weight loss, the patient is not having a family history, then go to second line. Trial of low dose TCA will be the answer in the exam. Please think 5 to 10 milligrams of TCAs. Tricyclic antidepressant is the answer in the AKT when you've tried the first line and they are not working. Keep your life easy, my friends. Well, you've tried your TCA 5 to 10 milligrams. Please, in the AKT, 50 milligrams amitriptyline is not the answer. It's wrong. I just said let me show you how this picture is created. Because someone will rush and pick amitriptyline. You fail the question. It's a loophole, it's a bottleneck. Understand the topic. Is low dose amitriptyline. So if you have gone to pick 50 milligrams, it's no longer low dose. Is no longer low dose. 25 milligrams in the AKT is wrong in the question. If you see, so this is how the question will come. They will say the first line hasn't helped. Which of the following will help? Option A, amitriptyline 25 milligram. Option B, sertraline 50 milligram. Option C, they'll put something else that won't help. Of course, they'll put hypnotherapy, they'll put hydrotherapy, for example, or they'll put some other things. That candidate will say, well, TCAs like amitriptyline are superior to SSRIs, so I'll pick TCA. Then they come and say, oh, I don't think I'm supposed to fail the question because amitriptyline is on the guideline. My friend, you failed that question because the guideline is clear. It says low dose amitriptyline is 5 to 10 milligrams. And these are the nitty gritties. Sometimes you cannot always exhaust the guideline. Sometimes you read the guideline because you were reading too fast. What you just saw there is amitriptyline can be used. You've forgotten that in front of the amitriptyline, because you were scanning and because the NICE guideline is not especially easy to read, it's not enjoyable. Because you were scanning through it, you forgot to read the low dose. You failed that question. 5 to 10 milligrams is the answer in the AKT. 25 milligrams will never be the answer. 50 milligrams is never the answer in the AKT. SSRIs will be the answer of the question I've just posed to you. 50 milligrams sertraline, correct. 75 milligrams sertraline, correct answer. 100 milligrams sertraline is still correct. It will come above 25 milligrams amitriptyline. So, my friends, you need to be able to think this way. And moving on, if you've tried TCAs, you've tried SSRIs, CBT is an answer, especially if things are not resolving, especially if the patient is starting to have low mood. TCA, because IBS, please, all chronic diseases are a cause of low mood. All chronic diseases are a cause of low mood. COPD, you need to refer at some point. When they start becoming low, refer for counseling. Asthma can be, especially if the patient is having regular clinic attendance. These are all causes of low mood. So IBS is one of them and is a cause of low mood. So I just thought I should give you a picture of IBS. I thought you shouldn't fail it. Let's look at how to manage IBS with lifestyle. So you've seen the management with medication. Please, please, and please, for everything that requires lifestyle modification, start with that. I've put 833. Someone is saying I've seen 833 before. Yes. When we're talking about urge incontinence, we're talking about stress incontinence. Remember, we spoke about pelvic floor exercise. 8 contractions, 3 times a day for 3 months. Don't fail the question. 833 deput. Don't fail the question. 8 contractions, 3 times a day for 3 months. Your deput is duloxetine. Pelvic urethral tape will come before duloxetine in the exam. Don't fail the question. If you were not in that class, go and watch the video. Go and watch the video. Anybody that fails a question on stress or urge incontinence, I will be pained. You will equally be pained because that may be your passing mark. You will equally be pained because you dash the AKT an easy mark. Don't fail these things in the exam. Bladder diary is 3 days. Bladder training is 6 weeks. I don't know how people fail these things. It's so easy. Training 6 weeks, diary 3 days. Well, if you see the question in the AKT, oxybutynin is the answer. Tolterodine is the answer. Dariferacin is the answer. So soliferacin will also be the answer. But this woman is 75. She's very frail. How do you give her an anticholinergic medication? The GMC will knock at your door, my friend, because she will have a fall, she will injure herself, she will have an intracranial bleed. It's all because you gave an old, frail patient an anticholinergic medication. Give her mirabegron. That's the answer in the AKT. My friends, this is how to think. And I beg you, the biggest problem in the AKT, I've said it 5 times today. I'm saying it because we've just finished your mock. Thinking is the whole exam. Many of you know these things. At some point, I just asked, these things I'm teaching, I know these guys know it. But my job is to help you to think. How do you think? You need to think that way, that a patient who is having mental health problems, the answer is mirabegron. And that's why they slip it into the question. They say she's 82-year-old, she's frail. That word frail has changed the answer from oxybutynin to mirabegron. But that candidate hasn't seen it. The candidate says, yes, I've gotten this question. Finally, I've seen a question I know. After I failed question 1, 2, and 3, at least question 4, I've gotten it. It's oxybutynin. My friend, you failed it. It's Mirabegron. Look at that thing. Look at that. Changes the answer. Amitriptyline, I've showed you. The thing that changes the answer is the low dose. In this as well, what changes the answer is the frail woman. That word frail has changed your answer. If you know what the examiner is all about, you will look out for the changing point. If you get the changing point, you hit the nail on the head. You got the answer. Well, I don't believe anybody should fail it. 833 here is restrict the amount of fluid in a day to 8 liters. It shouldn't be more than 8, please. The cups of coffee and tea they should drink not more than 3. They should drink up to 3, but not more than 3 a day. The fresh fruits, please, not more than 3 portions. 3 portions of fresh fruits, correct in the AKT. More than 3, wrong. The things to avoid, I thought I should repeat some of them. If you are giving a patient sorbitol in the AKT and the answer, the question is talking about IBS, you failed the question. Sorbitol will only be correct as which of the following should be avoided in IBS. That's the only time you see it in IBS. Lactulose, have overemphasized on it. I don't believe one of these candidates writing the exam under the Easy Learn program will choose lactulose as the answer. Please don't do it. It's self-harm. How do you know the answer is not acupuncture? And because they say the patient is having pain, you say, yes, I'll pick acupuncture. No! Acupuncture is the answer in tension headaches. It's preventive. Acupuncture is the answer in tension headaches. Amitriptyline is another answer in tension headaches. It is not the answer in IBS. Don't fail the question, my friends. Don't fail the question. Amitriptyline will be the answer in tension headaches. It will also be the answer in IBS. Look at how I contrasted them. Acupuncture is the answer in tension headaches, but in IBS, it is not the answer. But amitriptyline will be the answer in both. It's just that one is low dose, the other one can go a bit higher. How do you feel it in the exam? Okay, so you've known that lactulose, acupuncture, sorbitol, no. Everyone knows about the low FODMAP diet, so I'm going to leave it. If you don't know, the only thing you need to know, go and know the examples of low FODMAP diet. That question can come. They say, which of the following are examples of low FODMAP diet? We can't teach it here because there are quite a lot. So it's something that you sit down on your own, you look at them. What are the FODMAP diets? You find a way to understand which ones are low FODMAP, which ones are not. In real life, that is the work of the dietitian. In the AKT, they will ask you to know whether you know what low FODMAP diet is. That's why you have to, some of these things, you just have to know them. Have them at your fingertips. It doesn't hurt to even know them. So go, after this class today, I'll be expecting one of the smart candidates to spend 10 minutes to just quickly look at low FODMAP diet and understand the examples.